Hello, 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 everybody. Welcome to, I think it's episode number 7, lucky number 7 of Burning Migraine Questions. My name is Zeev Peled. I'm a plastic and peripheral nerve surgeon with a specialization in peripheral nerve surgery and specifically the surgery for headaches and chronic migraines, practicing here in San Francisco. We have, as always, a whole slew of really great questions. So we're going to dive right in. The first one on the list that is a holdover from last time is occipital neuralgia truly idiopathic? Or, in my experience, is the cause more often than not some sort of compression? Have you ever encountered inflammation of the nerve with no visible cause? A really good question. I think I've been asked a version of this many times by patients who are in the office when they sort of iterate, geez, I hope you find something if you're going to go in to my neck or in my head and face, because I wonder if you get in there and you don't see anything wrong, what will you do, or what does that mean? So the first part of the answer to that question is really, I have yet to see a patient and operate on a patient where in the operating room I never found some element of compression. The compression, for example, the greater occipital nerve can be as it interacts with the occipital artery or the occipital artery branches, which sometimes wrap around the nerve, kind of like an anaconda. It can be a spastic muscle. It can be where the connective tissue of the muscles in the neck, for example, the trapezius, connect at the base of the skull, and the tunnels through which the nerve passes are excessively narrow for any number of reasons. So there has always been some element of compression. Couple of caveats to that comment and that observation. Number one, we never had or have had a way to measure the degree of compression that we're seeing. So for example, if you were to examine a patient that you thought had something called compartment syndrome, which is a syndrome where you have compression of the nerves, the arteries, the veins, the muscles within the various compartments of the leg, there are established parameters for what that pressure should be in a normal patient and what that pressure is likely to be in a patient who has compartment syndrome, which is this diagnosis, and that's a surgical emergency. And there are ways and tools that you can measure that degree of pressure. We don't have that type of baseline for patients when you have nerve compression, so we don't have any way to really measure whether the degree of compression that we're seeing is excessive, so to speak, or not. The other caveat to the observation I just mentioned, which is that I've always seen compression, is that we don't ever really operate on people that don't have symptoms. There was a study that was done by Dr. Guyron several years ago now, and it's actually one of the landmark studies in the literature for headache surgery. And it is what is known as a sham surgical trial. And what that means is that in that study, he had 76 patients. 49 of them actually had the actual surgical procedure with the decompression, and 26 of them, or 27 of them, whatever the remainder is, underwent what's called a sham operation. So I have no idea how he got this past the Institutional Review Board, but we're all thankful that he did. Patients were consented such that on the day of surgery, Dr. Guyron would literally open an envelope, and that would tell him whether that patient would have the actual operation or the sham operation. And if they had the actual operation, he would operate on them just like he normally would. And if they were supposed to have the sham operation, because that's what the card said, the patient would be put to sleep, would be placed on the operating room table, would be cut open, and the nerves were exposed, but then left alone. And if you're talking about exposure of, for example, the greater occipital nerve, that may take 15 to 20 minutes, and the actual decompression procedure would take another hour. So in those sham surgical trials, I can only assume that, not wanting to give away that it was sham surgery, they had the patient asleep on the table, they opened up and exposed the nerve, and then basically just sat there and watched so that the operation wouldn't be over in 20 minutes, at which point the patients would know that they had the sham surgery. And what actually happened was that the patients who had, not surprisingly, the actual surgery did statistically significantly better in terms of pain relief, frequency, severity, duration of their headaches when compared with the sham surgical patients. In addition, none of the patients who underwent sham surgery ever got complete relief. There was a placebo effect. Some of the patients that had the sham operation did report feeling better afterwards, but none of them were actually headache-free, whereas a significantly greater number were headache-free in the actual surgical group. So, getting back to the observation, have you ever not seen any compression, just inflammation? I haven't, but if I'm operating on a patient's, let's say, right, greater, lesser, and third occipital nerve, because that's where their symptoms are, and they get near complete or complete relief when we block just those nerves on the right side, and they really never have left-sided symptoms, we will obviously not open the left side of the neck just to compare the right and the left side. So anytime somebody tells you that they've always seen compression, the caveat is we don't really operate on people who don't have symptoms and supposedly have normal nerves just to take a look at them. So we really don't have much of an actual comparison one side to the next. So that's a very, very good question. I'm glad you brought that up. Somebody had asked the different incisions that surgeons use. There are a couple of surgeons out there that use transverse incisions for the occipital area. There are some surgeons like myself that use vertical incisions, and those were the incisions that were originally described by Dr. Guyron. And I think we may have touched on this at the last Facebook Live session, so I won't make a big show of it this time. But the fact of the matter is that whatever incision you make on the skin, transverse, vertical, squiggly line, the real tail of the tape is what happens below the skin. And every surgeon should always use the surgical approach with which they are most comfortable and in which they were trained. You can certainly learn other approaches and then develop expertise in those other areas, but there has never been any study that has proven that one type of incision is better than any other, because really what happens underneath that skin incision is really what's important. So if you can get an adequate decompression of the greater occipital nerve, for example, with a transverse incision, that is a perfectly reasonable incision to use. If you use a vertical incision, that is also an incision that really works well and has been shown to be effective. And that's also just as useful and safe an approach. There was another question about whether or not I use botox injections for chronic migraines. There is an interesting set of papers, two of them actually, which are known as the Preempt 1 and Preempt 2 trials. These were the trials that first posited an effect for botox in treating chronic headaches. The issue that I've had with those trials are several-fold. First of all of the authors on those trials were either paid consultants for the company that makes Botox or actual employees of the company. And while that was frankly stated on the first page of those papers, which is fine and appropriate, you basically have a company that is putting out a paper that says that their product is really, really good. So certainly not, it doesn't necessarily at all invalidate the data in that paper, but it raises the question of a possible conflict of interest. And that always is a bit of a red herring in my mind when you have a company that has a scientific paper that says our product is really great, okay? That's the first thing. The second thing is the actual protocol itself. The original protocol called for 31 injections using 155 units of Botox, which is quite a lot, and it calls for these injections throughout the head and neck area. Now, many of the patients that I see don't have headaches or migraines everywhere. They have them usually the back of the head, sometimes the front, sometimes the temple. There certainly are patients who have headaches that they feel pancranially, meaning everywhere, but it's certainly not everybody. And so I guess the question I would have is, if your headaches are primarily here, why would you inject Botox here and here and here and here, et cetera, et cetera? The other issue I have with the data and the whole concept of Botox used in that way is that, let's say you have those 31 injections and you have 25 headaches a month, and you go from 25 headaches a month to 0 headaches a month for 3 months until the Botox wears off. My question to that patient and to the clinician performing those injections is, which of those 31 injections was responsible for that great result? And the answer is, you don't know. Botox takes several days to become effective. And if you're doing 31 injections in one setting, and 5 days later you have no headaches and you don't have any headaches for 3 months, you have no idea which of those 31 injections was responsible for that great result. Do you need 31? Perhaps. Maybe you only need 21, or maybe you only need 1. And the answer is, therefore, you don't know. So the protocol is to continue to get 31 injections every 3 months for the rest of your life. And that does not seem like a really great, certainly optimal strategy if you're in the average demographic, let's say 35-year-old female who's looking at 50 years worth of Botox injections. The other issue with Botox for chronic migraines is that as peripheral nerve surgeons, we actually used a lot more Botox in our initial experience. And this was Dr. Guyron, myself, Dr. Duchik, all the people that you've probably heard of. Very few of us use Botox anymore for the following reasons. When you use Botox, for example, in the glabellar area, you will see that the ability to furrow your brow like that probably goes away. And if you had 20 migraines a month and now you only have 2 migraines a month for 3 months, then you can presume that there was some muscle compression that was to account for your headache symptoms, and therefore you can offer that patient an operation. However, if you're unable to do this and you still have headaches, you haven't necessarily ruled out the possibility that there is a compressive object causing that headache, because the compression at the supraorbital and supratrochlear nerves can sometimes be the supraorbital artery or the connective tissue at the orbital rim. That's the top of the eye socket. Those structures will not be nearly as affected by Botox because they're not primarily muscle, the same kind of muscle that you have in your corrugators and your procerus. And so a negative result with Botox can be a false negative result because there could be other compressive structures and you won't know that if all you have is Botox. And so for that primary reason, a lot of us have moved over to just using nerve blocks, which not only numb the nerve irrespective of what it is that is compressing it and will therefore demonstrate relief, but also the results are immediate. You'll know within a few minutes whether or not that the appropriate nerve is numb because the skin territory, that the nerve innervates will have gone numb, and you will have a sense from the patient whether or not their pain has been relieved. So there was someone that was asking, what is the opinion on occipital nerve blocks for neck pain relief and how often should they be done? This person said that they currently get them every 2.5 months. We touched on this last time, and one of the most important factors with regard to nerve blocks is, for the most part, they are not, in my humble opinion, treatment modalities. They are like diagnostic modalities. If you injure your knee and you have an MRI and the MRI shows that you've torn your ACL, the MRI obviously does not fix your ACL, but it is a diagnostic modality. It shows the orthopedic surgeon, it's not a torn meniscus, it's not a posterior cruciate ligament, it's the anterior cruciate ligament, or the ACL, and so therefore the operation that we need to do to fix your knee and make your pain go away is an ACL repair, okay? Nerve blocks, in my opinion, work the same way. They are like any medicine that you try. If you have hypertension, you don't take a antihypertensive pill and go, that's it was easy, I'm fine now. No, you have to keep taking that pill because eventually your body will metabolize that medicine and your blood pressure will go up. So you keep taking the medicine to keep the blood pressure low. Insulin for diabetes works the exact same way. And nerve blocks are like any medicine. If the problem is nerve compression and you get a nerve block, the nerve will be temporarily and chemically inactivated. And if that nerve that you blocked is at least partially responsible for the overall pain complex or the pain severity will decrease temporarily. When the nerve block wears off, the pain will return. And so therefore, nerve blocks, in my opinion, are not meant to treat anything. They are meant to diagnose things. Some people do report that they have relief that can last several weeks or several months with a nerve block. Typically, those blocks are done with steroid, and the actual local anesthetic is just a carrier for the steroid to help inject the steroid near the nerve. Now, I suppose that in those few patients who predictably and consistently get, let's say, 3 months of relief with a nerve block, and I mean significant lasting relief for 3 months after a nerve block, I suppose it is reasonable to go see your physician every 3 months and just get a nerve block, and that will totally manage your headache symptoms. If it really works that way, I think that's a reasonable approach. However, if the nerve blocks only partially or minimally improve your pain, or if they only relieve your pain 100%, but for, let's say, 3 weeks instead of 3 months, then they are not that effective and are not a good long-term treatment strategy, because anytime you use steroids, you cannot use them too often or you will mess with the hypothalamic pituitary axis and you'll have all sorts of other problems. Just take a look at anyone who unfortunately has to take chronic steroids for Sjogren's syndrome or rheumatoid arthritis. That's really bad. And you'll see that they have a lot of facial fat deposition in the back of the neck that's called the buffalo hump. So these are not great long-term treatment modalities. And so therefore, in my opinion, nerve blocks are not something you want to do every so often as a treatment. Okay, so hopefully that makes sense. There was a patient here that asked about a rebound headache after an occipital nerve block. So that's a really good question, and one that has come up many, many times for my patients in the past. There's a couple of reasons why. If you have, let's say, pain every day and it's a 5 out of 10, and then every once in a while the volume on that pain gets turned up and it's an 11 out of 10, and that's what you call a migraine. So you come to see me and we do, let's say, blocks of the greater, lesser, and third occipital nerves. And for a few hours, your pain is 1 or 0. Okay? But then, as I said, the medicine will wear off because it's not a treatment, it's a diagnostic maneuver. And so then the pain comes back, and the pain can come back worse. Why would that happen? Well, there's a couple of very common reasons and probably one very, very rare reason why that could happen. The first common reason is a bit of a Jedi mind trick if you really think about it. If you have pain constantly all the time, you kind of get used to that level of pain, and I see so many patients in the office who look like they've constantly been beaten down because they just live in this kind of chronic, horrible, really uncomfortable state. And you do these nerve blocks and you walk back in the office, and next thing you know, the patients are sitting there and maybe they're not quite smiling, but their eyes are open. And usually their loved one is sitting there crying and looking at their husband or wife and saying, that's the person that I married 10 years ago. You brought them back, if only temporarily. But when the pain comes back because the numbing medicine is worn off, it can feel that much worse because you've had a window into what your life would be like or could be like again if that pain were to go away. So one of the reasons, and it's psychological, and it may not actually be what's going on, but one of the reasons I believe that the pain after a nerve block can be worse is because it was so relieved with the blocks that it seems that much worse afterwards. Another common reason I think that you will have some pain or an increase in your pain after an injection is because, of course, you're poking the muscles around the nerve, because a lot of these nerves pass through muscles, especially in the neck and certainly in the temporal area as well. Anyone that's ever had a tetanus shot, and I've had many in my life where you get the little poke in the shoulder, or when you're a little kid, sometimes your tush, knows that, boy, that shoulder is really kind of sore for like 3 or 4 days after, and it's this little tiny needle. Gosh, and it feels like I did about 500 these lateral arm raises. And the reason for that is because anytime you poke through the muscle, you have some inflammation of the muscle, and the muscle can get very sore. So when you're doing a nerve block, even if you use a very, very tiny needle, we often use very, very tiny needles. If you're injecting the muscle can be very sore after the injection. That can last several days there afterwards. So that is another reason why you can have increased pain after a nerve block. A third reason you can have increased pain after a nerve block is that you're actually putting a little bit of volume, which means a little bit of pressure. So even though the local anesthetic, it looks like water, it's not water, but it has the consistency of water. It's a clear liquid that is not viscous at all. It literally looks like water. You are injecting, let's say, 2 milliliters of that anesthetic right around the nerve. And if that nerve already has some pressure on it, you actually increase the pressure a little bit for a short period of time until that medicine gets absorbed and the effect of the nerve block wears off, which would be the numbness as well as hopefully the pain relief. The addition of that little bit of pressure for that little bit of time can actually aggravate the nerve and make the post-anesthetic period actually more painful, because you've kind of irritated that nerve a little bit more, not enough to significantly worsen you forever, but enough to make things uncomfortable as the numbing medicine wears off. So those are the three very common reasons why you may actually have increased discomfort after a nerve block. The fourth reason, which is really a very esoteric reason, is if you actually and accidentally do an intraneural injection. So you never actually want to inject the local anesthetic into the nerve, because if you do that, you can actually compromise and damage the nerve itself. The local anesthetic is meant to be ladled on top of the nerve. Now, fortunately, any of these nerves that we're talking about in the head and neck area are actually kind of hard to find. They're really small, tiny nerves. That's why I sort of say in my operative notes and when talking to other clinicians and patients, this is really kind of micro neurosurgery. So even under high-powered loop magnification, these magnifying glasses that we wear in the operating room, sometimes these nerves are very difficult to find. So the idea that you could subcutaneously or transcutaneously rather actually put a needle into the nerve and then inject it is pretty unlikely. And it would be literally like finding a needle in a haystack. However, if in the very, very rare circumstance you actually do a neural injection, you can actually cause damage and significant irritation to that nerve, and that can actually cause significant discomfort afterwards. So I think that those are hopefully a good answer, a reasonable answer, and that they make sense. However, I see lots of patients in the office who are really scared because they had a bad experience with another physician. You know, one of the other things that happens is when you inject this local anesthetic, if you inject it very, very quickly, you can actually cause a lot of discomfort. So I always do my injections fairly slowly. We obviously use as small a needle as possible to actually get to what we need to do. So there are nerve blocks, and then there are nerve blocks, and just because you've had a bad experience in the past does not necessarily mean that a future nerve block will be as bad or really bad at all. Nobody likes getting shots. I don't myself, but they can be very effective, and I've seen a lot of patients in the office over the years who say, I'm really scared to do this, and then after I've given them my injections, they're always like, wow, that was it? I can't believe it. That was so much better than the other time I had it. And things, you know, they get a lot calmer about it. There was a patient who asked a really interesting question as well. This patient was told by another provider never to get nerve decompression surgery. They said eventually the nerves will grow back and regenerate even worse and can cause more pain. And so the question was, can nerves regrow, and can scar tissue prevent subsequent decompression surgery? So there's a lot of questions in there. I think this will be a kind of a longer answer. But the simple question is, first of all, if you're doing nerve decompression surgery, by definition, you're not cutting anything. And so any surgery can always injure the structure you're after. Okay, so if you are going to go do a gallbladder, you can actually, a gallbladder removal, you can actually injure the liver around the gallbladder or the bile ducts that lead to the gallbladder. And similarly with nerves or with tendons or bones, you can actually injure the nerves that you're trying to operate on. However, most of the time, if you're an experienced clinician and you take care in the operating room, the chances that you'll permanently injure a nerve is extremely, extremely low. And you're not cutting anything, so the idea that that decompression could cause the nerves to be further damaged is possible, but extremely unlikely. Now let's say you get into the operating room and you find a nerve is permanently damaged, and you test it like I do and there are no muscle twitches, which means it's a sensory nerve and likely the one that you're after, let's say the greater occipital nerve. If you cut that nerve, like with any nerve injury, whether you cut it, burn it with radiofrequency ablation, stretch it in a whiplash injury, nerves will always try to regenerate. That is what they do. So if you have to cut a nerve, you have to do something to mitigate the effects of that nerve regeneration. And the easiest thing to do, and the simplest thing that often works extremely well, is to bury that nerve in the muscle. The person who trained me taught me and published a small series of patients in which he went back to look at nerves that he had buried in the muscle. And when you cut that nerve, and he biopsied those nerves, this was an animal study, and he had the pathologist look at them under the microscope. Now, the actual definition of a neuroma, which is a painful nerve ending, is a histologic definition. It means that when you take a nerve, cut it out, and then cut it into thin slices like the pathologists do, stain it however they stain it, and look at it under a microscope, you will see two main factors. You will see regenerating neurons and scar tissue. And that pattern of scar tissue and regenerating neurons typically has a certain pattern. When the person that my mentor went back and looked at the nerve ends that he'd buried in the muscle, the architecture of those regenerating neurons was different than in the typical neuroma, where a nerve was cut and then left under the skin. So it was thought for many years that it was something about the muscle milieu that you're burying that nerve in that caused the neuroma, the regenerating nerve end, to not be a true neuroma, but a variation of it, and therefore a non-painful one. So essentially the nerve would go to sleep. I actually believe that there's a different process that goes on, and I believe this because we now, on purpose, actually do rewiring of certain nerves, and I may have mentioned this in one of my previous sessions, when we treat patients with phantom limb pain following an amputation. We also do the same procedure, which is called targeted re-innervation, in patients whom they've had pain, but want to also be able to power these complex myoelectric prosthetics that don't just have an open close, but have a wrist that articulates, fingers that move individually, so you can have really fine precision grasp with some of these really, really fancy newer prosthetics. One of the things that we have found is if we take a motor nerve, or sorry, a sensory nerve, or a mixed nerve, that is a nerve that has both motor and sensory fibers, and we attach that nerve literally by sewing it to a motor nerve end in the muscle, the pain that was caused by the sensory component of that nerve tends to get significantly better or go away. Let me say that again. You have a sensory nerve, you're attaching it to a motor endpoint, or I should go this way, all right? So now you have a sensory nerve talking to a motor endpoint, meaning the muscle. That would be like me speaking Hebrew on this פייסבוק לייב. הייתי מדבר בעברית פתאום, ואני מקווה שאין אף אחד שמדבר עברית, ופתאום אתם שומעים משהו, ואתם לא, אין לכם מושג מה אני אומר. What I just said was, you would hear me talking, and hopefully there's nobody here that actually speaks Hebrew, because you would have understood that, but there is no reaction, because you have no idea what I'm saying. And that's literally what we think happens when you take that sensory nerve and plug it into a motor endpoint. You have neural impulses that go through, but because you have a sensory nerve talking to a motor nerve, there is no reaction. However, because the pain goes away, what we think actually happens is, and we know this occurs to some degree, the neurons in that sensory nerve, they've just met other neurons in the motor nerve before it gets to the muscle. And so those neurons think, hey, I've met my downstream counterpart. I don't need to regenerate anymore. I've repaired myself. And therefore, that neuroma actually doesn't form. I'm telling you all this because what I actually think, and I think at some point we'll actually be able to prove this, when you cut a nerve and bury it in the muscle and it, quote, goes to sleep and gets better, what I think happens is that those sensory nerve endings are finding their way to coapt or join motor nerve endings within that muscle, and that targeted reinnervation thing that we're doing with larger nerves in the arm, for example, that we do manually is actually happening automatically when you bury a nerve in the muscle, and therefore that neuroma never forms and the nerve goes to sleep. So it is not necessarily the case, and I have hundreds of patients to prove this, and the literature shows that this is totally appropriate and the best thing to do. If you cut a nerve and bury it in the muscle, while there's always that chance that the pain could come back worse, it is very unlikely if you know how to manage that nerve end specifically by burying it in the muscle. Now, there are other techniques to deal with painful nerve endings that I would use as a secondary operation, but that's the primary one. That is all the time we have this week. Thank you very much for joining us. If you have any other questions, please feel free to email us. Go through our website, peledmigrainesurgery.com. We will continue to collate these questions. We have, as always, many more questions that I didn't get a chance to get to this week that we'll hopefully get to a couple of weeks from now. Stay tuned. We have an exciting, if you look at our website or follow us on Instagram or Facebook or Twitter, we have some exciting things coming up in the next few weeks that I think everybody should look out for. So thank you again for joining us, and hopefully we will see you again in 2 weeks. Take care.